Hi everybody, my name is Dr. Schnorr and I'm excited to be here with you all today on Facebook Live. I'm here with Holly, who is amazing, and she's helping us through all this. And the nice thing is Holly's going to be able to see any questions that you ask along the way, and she's going to be able to address those questions in the middle of the talk. So if you guys have questions during our talk that's relevant at the time that I'm talking, she's going to interrupt me and ask the question, we'll answer it. Otherwise, we'll just kind of stack the questions up for the end, and then I go over them at the end. For those of you who I haven't met, my name is Schnorr. I'm a reproductive endocrinologist. Reproductive endocrinologists have training through first OBGYN training. That was an OBGYN residency that I did in Charlottesville, Virginia, which is the Jones Institute. Amazing place. It was a great 4 years. I then did a 3-year fellowship at a place called the Jones Institute, which is in Norfolk, Virginia. That was a fertility fellowship, reproductive endocrinology. An amazing place. They had the first gonadotropin stimulated IVF baby in the world. I got a chance to work with Howard Jones and Georgiana Jones as they started the Jones Institute. Really amazing people. I learned a tremendous amount from them and will be forever grateful. And they came down to Charleston in 2001. We, at that time, worked at a practice called Southeastern Fertility Center, later created Coastal Fertility Center in 2012, and have been here ever since. I think probably some people know, and I'm happy to explain, my wife and I had some infertility along the way in our journey. I think early on I was a little bit interested in fertility, but then during residency we had difficulty having Courtney, who's our second child, and through some fertility treatment we got to success. And that just further drove me into the field, helped me understand some of the challenges that patients have with infertility, what a big challenge it can be, and have started Coastal Fertility as a result of that. My true belief, and that's something we're going to be talking about today, is that nobody has a 100% pregnancy rate. No fertility center does and no patient does. And so that means that to get through this and to have a family, you need persistence. Persistence is key to the whole thing. And you can only be persistent if you're in a place that you feel like you're loved and people care about you. And our whole premise in how we develop Coastal Fertility is to provide a compassionate, kind of loving center that's all in for you, that's going to do everything they can to help you. A testament to that is we have a tropical storm that's going to come in a day or so, and a lot of practices are shutting down. Coastal Fertility is not shutting down. Our staff members will be here because you're in the middle of your treatment cycles and you need somebody to help get you through all that. And so when the chips are down, we are still here for you and going to get you through that. Along that line of persistence and kind of what's next is a discussion about what do you do if you do a treatment cycle and it doesn't work? Do you just give up? Do you stop? How do we approach that type of situation? Our pregnancy rate at our center with, for example, the best embryos, which would be a chromosomally normal embryo from a relatively young patient, let's say less than 35 years of age, gives about a 70% chance of pregnancy. So if we put one embryo into the uterus and it's a really good embryo and everything's perfect, it's a nice transfer and everything's perfect, it's a 70% chance of pregnancy, which is amazing because when I was in training, the pregnancy rate was 8 to 10% per 4 embryo transfer. We would transfer 4 embryos and the pregnancy rate would be 8 to 10%. So to me, it's completely amazing that we can do a 1 embryo transfer and then get to that 70% pregnancy rate. But let's not forget there's 30% of people that are on the other side of that statistic where they didn't get pregnant. And the question is, what are we going to do next? So along those lines, we talk a lot about different treatments that we can do, how we can make things better. And so when things don't work, we like to spend time and figure out why it didn't work. Sometimes it's just that the embryo wasn't a good embryo, that it looked good, it grew well, it just didn't become a good embryo for us that was able to grow in the uterus. And studies show that of failures to conceive, probably 80% of the time, it's that the embryo was not a good embryo. Now, you might say, well, Dr. Schnorr, but you just said that was a chromosomally normal embryo. Well, remember, when we do chromosome testing, all we can really do is count the number of chromosomes that the embryo has. We all have 46 chromosomes in our body. We can check all of them to make sure that they're there. It's in a way like counting the number of encyclopedias on a shelf. Some of you might be old enough to know what encyclopedias are, others maybe not. I actually do know what encyclopedias are. Of course, you'd buy a whole encyclopedia set and you would pick up the right book and read whatever you needed to study. So the analogy is that we can count the number of encyclopedias on the shelf, the number of chromosomes in the embryo, but we cannot read at a paragraph level in the encyclopedia how to make kidneys, how to make a heart, how to put the heart in the right place, how to make the lungs work. We in medicine don't yet know how to do that. And so we can actually make sure that all the chromosomes are there, but we don't know at a genetic level if this is necessarily a healthy embryo. So often a chromosomally normal embryo has the right number of chromosomes, but is missing the things for metabolism and other things that are required for an embryo to implant. So again, about 70 to 80% of failures to conceive are likely due to the embryo. That leaves another probably 20 to 30% that are likely about the uterus, the environment, something was abnormal. Now that could be the embryo was absolutely perfect, but maybe the transfer didn't go well and the embryo didn't get into the uterus well. Difficult transfers can be a problem. You would typically know that at the time of transfer, so that would be one thing that we would think about. Another thing that we would think about is there something wrong with the environment? Maybe the uterus didn't thicken up appropriately. And so we know that there's a layer inside the uterus called the endometrium that needs to thicken up the right way so that an embryo can grow into it. We generally like an endometrial thickness on estrogen and progesterone that's generally greater than 6 to 7 millimeters. Generally, I tell patients if you get to 8 millimeters, we're golden. We celebrate 8 millimeters. Between 6 and 8, we're generally still pretty good. Below 6 millimeters, we do see lower pregnancy rates. And so it could be that the uterus wasn't healthy and wasn't ready. And so that would be something that we would look at. Sometimes there can be fibroids. Sometimes there can be polyps inside the uterus that can be a problem. And so we would look at and address those types of things. The next thing that I think we forget about is the environment that we've created for that baby, right? Do we have a weight problem, right? If our weight is up, it's 100% clear that as your body weight goes up, your pregnancy rate goes down. It's also 100% clear that as your body weight goes up, your chance of miscarriage goes up. And there's some really great studies that show that the most common cause of miscarriage is a chromosomally abnormal embryo. And therefore, most people are miscarrying because the embryo is abnormal. But there's some weight studies that show that if your weight goes up, you more likely miscarry an otherwise normal embryo that shouldn't be miscarrying, showing that the impact of weight is significant. Now, I realize that we all have weight challenges at different levels. And, if you have a body mass index of 38, 39, 40, which is on the upper end of kind of really what gives good pregnancy rates, we're not asking you to get to a normal body weight of 25 for a BMI. We just think that every 5 pounds you lose is going to have a significant improvement in pregnancy rates and it's going to have a lowering miscarriage risk. So sometimes you just need small adjustments to get where you're going. We all like wine. We all like maybe a beer every once in a while. Sometimes alcohol consumption we think can be a problem. And so we think moderation of all things. I'm not saying don't drink alcohol, but I wouldn't be drinking any more than 2 or 3 per week in that final week that I was actually going to get my embryo transfer. We think that becomes important. We think prenatal vitamins lowers the risk of birth defects, probably doesn't improve pregnancy rates, but lowers the risk of birth defects. Vitamin D supplementation, also probably a nice benefit for pregnancy rates. So those are things that we look at. And so if somebody had a failed cycle, the first thing we would do is try to understand, what did the embryo look like? Did we do genetic testing of the embryo or not? You don't have to do genetic testing to get a good embryo. Often you can be less than 35 years of age and not need genetic testing to get a good embryo. But how quickly did that embryo grow? Was it a blastocyst embryo? Was it a day 5 embryo? Was it a day 6 embryo? Was it a day 7 embryo? These are different metrics that we use to grade embryos. What was the size of the embryo? What was the morphologic grade of the embryo? And so if we look at that and say, well, the embryo looks somewhat compromised because it had a lot of fragmentation, it was growing slower, it was smaller, then we would start to say, I'm concerned that embryo may not have been a healthy embryo. And the question becomes, what do we do next? So if it's an embryo problem, one thing we would do is say, well, do we have any more frozen embryos and what are their qualities? And if that was the best embryo, which it likely is, you never go into your next cycle generally and transfer the worst embryo, you generally transfer the best embryo. So if you have additional frozen embryos and the first embryo didn't work, the question would become, is there something we can do to make this better? If you have another embryo left or 2 embryo left, we'd actually even start to consider a 2 embryo transfer. If we really are concerned about embryo quality, it's a legitimate discussion to transfer more than 1 embryo. It has the obvious risk of twins, which we don't love, but it is part of the discussion. Sometimes patients don't understand that not liking twins kind of thing that I said. I love twins. I just want them to be 2 years apart age-wise. And the reason I believe that is that a current pregnancy that's got 2 babies in it has a 7 times higher chance of having cerebral palsy and a 7 times higher chance of autism. And so to lower birth defect risk, we're always about trying to get a 1-baby pregnancy. But if we have lower embryo quality, we did a 1 embryo transfer, it didn't work, a rational discussion is discussed, maybe a 2 embryo transfer. Well, what if you're out of embryos and your embryo was bad? Well, then we have to go back and say, well, what made that embryo bad and how do we make it better? And so that, of course, involves eggs and it involves sperm. And most of that discussion comes about how do we make the egg quality better next time around. And so there are ways that we can adjust the stimulation to maybe change the suppression, to maybe be a little bit more aggressive on the medications. Sometimes we might use growth hormones. Sometimes we might trigger ovulation in a different way. There are a variety of different things we can change in that recipe that we use to help you make eggs. And it is a recipe. There are many different medications and ingredients and dosages and timing and other things we can do to look at that. Sometimes we can grow the eggs longer in your body and get a better egg quality. Sometimes we can actually mature them in different ways with different hormones. So we look to see how do we make that egg quality better. And then part of that discussion is going to go back to, by the way, how much alcohol are we drinking? Are we smoking tobacco? Where's our weight? You know, we want to keep that environment right because that's the environment the eggs are being made in. We don't want to ignore the sperm. We do think the sperm plays a role. Honestly, it's probably a fairly small role. We need sperm. With ICSI nowadays, we don't need a lot of sperm, but we do need good quality sperm. So if your male partner, you know, has a case of beer a night kind of history, that would be something we'd want to work on. Tobacco use, good. We do know that lowering a man's weight can be a benefit. There are different things like that that can make the DNA stronger and better and give us better outcome from a male side of the perspective. And then the embryology lab's important. It's important that you're at a center that has a very good embryology lab. You know, I believed very early on that it was more about the lab than it was the physicians. I honestly think we can both screw it up, and I think we need to both be hitting on high cylinders to make it work. But I think you need a really good embryology lab. I'm very proud of our pregnancy rates. We've invested a lot of time and effort and energy and emotion into getting the IVF lab we have. We have some of the highest pregnancy rates in the Southeast. I encourage you to go to our National Society's website to look at those pregnancy rates and see what we've been able to accomplish. We literally were audited about a year ago because our society was thinking we might be fudging the numbers, right? They were thinking that maybe our pregnancy rates are better than they should be. And they're amazing. And so we took it as a great compliment that they came and audited us because of our high pregnancy rates. Of course, the audit turned out fine. They found our pregnancy rates are accurate. They literally complimented us about 5 times on the way out, and that was great. And that website is www.sart.org. I'm going to give that to you one more time. You can also find it on our website, www.sart.org. So the embryology lab matters. So, you know, if you had a bad cycle someplace else, maybe we can make it better through a better stimulation, but also a better embryology lab, or at least a changed embryology lab. Right. And so Holly put that in the comments, which I appreciate. So that's how we make the egg better. What about making the uterus better? Well, early on we do ultrasounds to make sure there aren't polyps or fibroids or any structural abnormalities. And so we would do that, and if there are those, we can correct those and remove those. Sometimes if your uterus isn't thickening up the right way, we can actually change your dose of estrogen. Sometimes we give it instead of orally, we give it in the form of patches. Another way to do it would be giving it with vaginal estrogen. We take a vaginal estrogen tablet and put it in the vagina. I personally don't really care for that approach too much. I think that it gets estrogen too high, but sometimes it's appropriate to do that. For people with too thin of an inside the uterus, we might do a special surgery to look to see if there's any scar tissue inside the uterus. Sometimes we'll actually use vitamin E and L-arginine. There's some studies actually of all crazy things using Viagra, where a woman gets Viagra, and that would increase blood supply to the uterus, and more blood supply to the uterus helps to thicken up the inside of the uterus. Sometimes it's as simple as using the same dose of estrogen but waiting longer for the uterus to thicken up a little bit better. That can be a benefit. And then the other thing that I think we're really starting to understand in our field is the impact of a cesarean section scar, that some people have had prior C-sections and the scar can get a defect in the center of it. And that defect in the scar can make it so that it actually seems to lower pregnancy rates. That's called an isthmocele is the name of that. Some people would call that a uterine notch. And if that's there, sometimes surgery is needed to put that back together to get that better. And so that can be another cause that we look for. So we look for the uterine causes, we look for the kind of whole body causes, and we look at the embryo causes. Sometimes, sadly, we go through all that and it all looks normal. And it just means that, it was a bad roll of the dice. And that goes back to that early thing that I talked about, that persistence is key to success. And so the person who scares me the most is the one who comes in and says, Schnorr, you get one try at this, we're giving up, we're then not going to have any kids. I would much rather have the couple that's got every odd against them, that they say, Schnorr, we're going to do whatever it takes to get through this, and they will get to a pregnancy. There's nobody who we've been unsuccessful with in this entire institution if they've been persistent. And so you can be without a uterus, you can be without eggs, and you can be without sperm. And we're going to have to get creative in a situation like this, but with persistence we can get that done, right? Egg donor, sperm donor, and what we call a gestational carrier. And that will give you about a 70% chance of pregnancy per try with the gestational carrier, and with persistence you'll get there. And I've seen many a patient who did just that, who had the persistence. And I love people who have the persistence. And our job is to provide the nurturing support, the good embryology care, the good physician care that gets you to that ability to have the persistence that you're going to need to have a high pregnancy rate. So I'm going to stop there. I know that there are some questions that came in. I look forward to answering everybody's questions. Again, I'm Dr. John Schnorr. I'm at Coaster Fertility Specialist. We have our main office in Charleston, which is in Mount Pleasant. We have an office in Somerville, which is in Nexton, kind of the Nexton area. We have an office which is in Lexington, which is a suburb of Columbia. We have an office down in Savannah, and we have an office up in Myrtle Beach. And the reason we have those offices is in that same compassionate, nurturing environment tone. We don't want you to have to drive as much. And so we've invested all of our money and resources into this embryology lab that we're so proud of. We're not able to put it on wheels. I would love to put it on wheels and drive it around to everybody so we do it in your backyard. Maybe you have a swimming pool, that'd be even better for all of us. But since we can't drive the lab around, the doctors drive to you, and we're at those regional offices to do that. So I'm going to hand this over to Holly.
Okay. The first question is easy. Will this be available? Will this video be available on our page after?
Yes, we're going to record this video, so if in the future you want to watch it, you're welcome to do it.
It'll be posted on the page. Okay, second question. Is there an AMH that is too low for IVF that would she need an egg donor? Is she asking?
So the question is about AMH. AMH is a measure of egg quality. It's called anti-Mullerian hormone. And so when we think about eggs, we think about egg quantity and we think about egg quality. The best measure of egg quality is your date on your birth certificate. Your age tells me your egg quality. And so the younger you are, the better the egg quality is. AMH tells me the egg number. And so if you are older and have a lower quality of eggs and have a lower number of eggs, that's a pretty sizable challenge that sometimes we have to treat with egg donation. If you're younger and have quality, we're in a little bit more luxurious position. And so I would say there's generally not a number of AMH that you have to have, but we get concerned about AMH levels less than 1, and particularly AMH levels less than 0.5.
Okay, great. Something that isn't on here, but we get asked a lot is, can you talk about affording care and the shared risk plan that we offer?
Right. So questions about finances. Finances matter a lot. I never forget, I had one of my daughters, we brought her in to get braces. And the orthodontist said, we're going to do this, we're going to do that, and we're going to fix everything. And I said, that is fantastic. I'm grateful for your help. How much is this going to cost? And the orthodontist said, well, we don't talk about finances. And I thought, well, that's like the worst, right? I mean, it's the real part of this, right? What does IVF cost? Well, about 60% of all patients now seem to have some form of insurance coverage. And if you have an insurer, an employer that doesn't have coverage, I strongly encourage you to look for either a part-time job or a different job that does have coverage. For example, if you work part-time at Tractor Supply, if you work part-time at Starbucks, if you work part-time at Walmart, there are many places you can work to get a job. Cost of IVF, around $12,000 to $15,000 is the typical cost with medications, ultrasound, embryology, surgery, anesthesia, everything start to finish. That's real money. And so if you can get a part-time job folding clothes, listening to country music at Tractor Supply for 3 months so that you get $15,000 functionally that pays for your IVF cycle, that's a pretty good deal. So I would recommend that. We do accept most insurance carriers, and we're proud to do that. If your insurance doesn't cover you, there are options for you, and one option is a shared risk program where you can pay for more than one cycle up front for a discount, or you can get into a shared risk plan, which if you don't conceive, gives you all your money back. And so that is an option that we offer.
And that's all for the questions. The only thing I would say is if anybody has any topics that they would like us to cover in future Facebook Live events, let us know.
Right, and so Holly brought up a very good point. We love doing these outreach videos, and we encourage you to put comments on Facebook to let us know what you'd like to hear about. We did one on cost before where Shannon was involved. We did one on an embryology lab, which was good. We did one on IVF and IUI before. Of course, today was about failures to conceive. We have other interesting ones we do, but we'd love to hear about you and love to hear about what your thoughts are. I know there's a tropical storm coming, so be safe, and I enjoyed spending time with everybody. Take care. Bye-bye.